Welcome, everybody. Today's presentation will be addressing medications for managing pediatric sleep disorders. I always I always start by saying how difficult webinars are because I tend to walk and move around during my live presentations. So sitting for a webinar is a little bit difficult for me, but we're going to push through it as if the camera's not here as well. We appreciate you taking the time, and I appreciate the opportunity to be here with you today. By way of disclosure, aside from my duties here at the Florida International University Herbert Wertheim College of Medicine, I am a consultant for the Florida Medicaid Drug Therapy Program for Behavioral Health there at your sponsors at the University of South Florida as well. I do not have any other relevant financial disclosures to report, though. As we go through to today's presentations, these are the three broad objectives that we will be covering today, with the large majority of the emphasis being on the third objective, where we will discuss medication treatment for sleep issues with children and adolescents. Then we're going to particularly focus on what the evidence base that helps us guide to make these decisions or not make these decisions. If you're expecting an overview of non-pharmacologic management of these sleep issues, this will not, we're going to cover those very briefly, but that goes much more or farther beyond the scope of this presentation. So be alerted that we're going to, like a movie, this will build up to a crescendo where we talk about meds, but we will not cover in detail what a very important topic, which is the non-pharmacologic or the behavioral management of sleep disorders in children and adolescents. So let's start with the general basis of what are sleep issues or sleep disorders within the pediatric, the child and adolescent population. And why is that important? Because we need to understand what typical sleep is before we get to see what is a disorder or what is clinical or something that would require a treatment intervention, and much more so a pharmacological intervention. This graph shows the typical 8-hour sleep cycle in adults. By way of introduction, you see that our typical sleep cycle is anywhere from 90 to about 110, maybe 120 minutes, but 90 to 110 minutes, with the earlier phases of sleep in the night being much deeper sleep. Then as the night progresses, our sleep is less deep and therefore leading to awakening later. When we look at what are the expectations or typical sleep patterns for children and adolescents as they develop from birth through about 18 years of age, you can see there are these marked changes that occur developmentally. And a lot of this happens in the infancy, newborn, and toddler age ranges. And then it kind of levels off into a more of an adult-like pattern. So let's break it down a little bit by phases of development, starting with the far left of the screen when we talk about the newborn. And again, these are gross or rough estimates of what is typical. To the sleeping about 11 to 18 hours per day typically, to an infant that sleeps about 14 to 15 hours per day, to a toddler, which again becomes shortened a little, 11 to 14 hours per day, to a preschool child, 11 to 13 hours, leading on to a school-age child. In school age, generally we presented as 5 or 6 years old to about 12-ish years old, to the typical adolescent, 13 and above, where the expectation is 8 to 10 hours, although as you'll hear, and many of you already know, adolescents do not typically sleep 8 to 10 hours in a typical weeknight. If we review these in a little bit more detail, not only the quantitative portion of the sleep, some of the qualitative or some of the sleep issues that are typical during these age periods, you'll see that in newborns, the sleeping is basically around the clock, and a lot of the sleep-wake cycle interacts with these biological needs, such as the needs to be fed or nurtured or changed when they have a bowel movement or urinate in their diapers. And that their sleep period is very irregular. They could last from minutes to hours, but as we saw, it's quite a few hours throughout the day, so that the predominant amount of time during the day is in sleep mode. As the newborn transitions into infancy, the frequency of nighttime feedings usually becomes less, and the figures put it at about 70 or 80% of infants have zero or few feedings at night by about 9 months of age. Now, we all know certain babies that really don't do that, and we're all blessed if we're able to have these kids that have this kind of biological predisposition or this temperament where they'll really get into that sleep pattern throughout the whole night, but that in general, the majority of kids by about 9 months of age are sleeping throughout most of the night. Then the kids, as you can see, as they develop into infancy, the amount of daytime sleeping becomes less and less. And one important point which helps with sleep issues, and something to talk about with parents prospectively, is that has to do with sleep routines. So that we know that infants that are put to bed when they're in this transitional or drowsy sleep, but not fully asleep, are more likely to be the so-called self-soothers. That is, that they're able to calm themselves back down and then fall back asleep whenever they do awaken. Whereas the kids where they fall asleep either in the parent's hands or somewhere else, and then are put in the crib or put in the bed to sleep when they're already asleep, tend to be the so-called signalers. That is, that they tend to cry and need much more picking up during those periods when they awaken, and don't tend. I mean, it's a little bit more difficult for them to transition back to sleep on their own. When we look at toddlers about 12 to 24 months, you could see, obviously, as we've mentioned over and over again, the total quantity of sleep decreases during this time period. And needless to say, their nap time begins to decrease. Starting in this age period, one of the basic notions we know about sleep is that then the naps should not occur too proximal or too close to the bedtime, as they, even in toddlers and older kids, may interfere or delay the onset of sleep. And it's roughly around here when sleep issues start being picked up and being displayed by the kids at this age, including the fears and the nightmares that are relatively common. Hence, common being developmentally appropriate, and that hopefully not necessarily pathologized, as we'll get to a little bit later. Preschoolers, typically kids, one of the things we do see in that same vein is that preschoolers start to develop even more frequently nightmares and fears at night, as they cognitively develop, then you start seeing all those issues around this age period. And it involves some other sleep changes, which could include either sleepwalking or even sleep terrors. So that these sleep issues that peak around this time, as long as they fall within a certain spectrum of severity and frequency and are managed appropriately, are not considered clinical, that is, needing any major clinical interventions, but as any parent will tell you, they can be challenging at times as well. Now, in school-age children, just from that emotional perspective, we see that these emotional issues continue to extend, and that, yes, more fears are not uncommon, Anxiety is relatively common in kids. Anxiety disorders less so, but anxiety as a common phenomena is. And anxiety at nighttime, around falling asleep or around waking up during the night, is relatively common. We also then know that as kids transition into elementary and middle school, the academic demands, the schedule demands start interfering and create at times issues for the management of schedules and sleep in general. And then lastly, as we all know, issues such as screen time, using the portable devices, the TV, the computer, the internet, and all these other screen-based devices begin to create potential issues for kids, especially those that are biologically predisposed to have difficulties with sleep. And anywhere from difficulties initiating sleep to disruptions or continuation in their sleep cycle. And it's around this age that the sleep problems become a little bit more prevalent. So although they can be seen, the clinical sleep problems, right? They can be seen earlier in preschool and infant. It's around the school age years that these start spiking a little bit more. And then we have adolescence. Then we know that a lot of changes happen in adolescence. Then stereotypically, teenagers want to fall asleep later and want to wake up later, but we know that classically that's not consistent with the typical school schedule, whereby in most school districts, the kids enter school earlier than the middle school or the middle childhood kids. And that creates all kinds of issues on multiple levels. Because a typical teenager, as we mentioned earlier, would require about 8 to 10 hours per sleep. Although if you ask any parent or any clinician who works with kids, you'll see that most teenagers, aside from the weekends or holidays, do not sleep 8 hours a night. And that therefore these irregular sleep patterns also contribute to issues. That is, issues of staying up late or having to get up early, having less total number of hours of sleep during the week, and then either staying up later on the weekends or falling asleep later and waking up later on the weekends, and then having to transition back that schedule on Sunday to Thursday can be quite difficult for teens. And a lot of estimates report that about 85 to 90% of adolescents do not get the recommended amount of sleep on school nights. So we know that this is a very, very frequent issue that is dealt with on a day in and day out basis. So that is a brief introduction that serves as the basis as to what is considered normative or non-pathological or non-clinical. And why? Because one needs to know what's developmentally appropriate to then kind of look and see what would be considered clinical. So as we transition into what is a sleep disorder, in the pediatric world, there are two big classes of sleep issues. And they're the dysomnias, and the other are the parasomnias. And there's a whole host of other sleep issues that go beyond the scope of this presentation, but these are the two main ones we will focus on. And we're going to see that the medication discussion is going to focus primarily on dysomnias, that medications have a smaller role in parasomnia, so that almost exclusively our discussion will be on dysomnias or insomnia. So kids with dysomnias present with difficulties either initiating or maintaining their sleep, and or having excessive daytime sleepiness or somnolence from their sleep issues. In our current nomenclature, our DSM-5, our Diagnostic and Statistical Manual, fifth revision, is called an insomnia disorder. In the previous iteration of the DSM, it was called a primary insomnia. So these dysomnias include changes in how efficient the sleep is, how the sleep wake cycle is, and how the qualitative or the sleep architecture is. And we know that many of these patterns that begin in childhood can be these lifelong patterns. So if anyone that works with adults, if you who have sleep issues and you go back and you get their history, you see how chronic this is. And why is that important? Because then that helps set some of the goals and expectations as to what you'll do with adults, depending on it being more acute or situationally related sleep disturbances. So as these sleep issues we're looking at primary sleep issues, which are associated with disturbances in the quantity, the quality, and the timing of the sleep. That is, when do I fall asleep, or how late does it take, the latency, how does it take for me to fall asleep? And so the problems are usually broken into three categories, right, with these sleep issues. And the first one is difficulty initiating sleep, what some people categorize or term initial insomnia or early insomnia. And in children, this includes difficulties falling asleep without the parent or the caregiver. And that's a little bit different than with adults, right? Because the child may fall asleep very readily and easily with the parent, grandparent, or any other major attachment figure, caregiver. But when they try to fall asleep independently in an age-appropriate way, right, depending on the age, then they have difficulties falling asleep. And so, although it's subjective, there's a general consensus that the sleep latency, the time from when a child gets into bed and to when the child actually falls asleep, if it's greater than 20 or 30 minutes, then that's usually considered an issue or a problem. So that 20 to 30 minutes is a rough time period of what's typical for someone to fall asleep. Hopefully sooner, especially if you're a tired parent after a long day at work, but 20 to 30 minutes would be what you would look for in the history of a child who is displaying difficulty initiating sleep as a start to seeing if the criteria is met for a sleep disorder. In children who display difficulty maintaining their sleep, this usually means interruptions in the sleep. Some persons call it middle insomnia, that is, waking up during the sleep cycle at some point during the evening, and then again having difficulty falling back asleep without the caregiver. Now, again, that's an important point in children compared to adults, because many children will transfer to the parent's bed and fall asleep very readily, but over time, one looks and say, hey, is that developmentally appropriate for that child to be sleeping in their parent's bed every night or most nights? And you'll have to answer that, because there are some cultural factors related to that, but there are obviously some very clear developmental expectations as to when that occur. And sometimes I'll ask the parents, how long would you like to let this happen? Until they're 8, 10, 15, 20 years old, as a way of trying to come to some clear expectations as to when they expect it. Then we get into this whole discussion about winning the battle, but in the proverbial long-term war, how that may not help. And so that in general, by middle childhood, most children should be sleeping independently without their parents, or falling asleep or returning to sleep without their parents on most nights. Exceptions would include things like when they're ill, or when there's a terrible storm, or something terrible has happened very proximal or recently, and that creates some issues as far as emotionally and difficulty staying asleep. So with difficulty maintaining sleep, again, the parameter is roughly about 20 to 30 minutes. If the child gets returned or gets in their bed in the middle of the night and takes more than 20 to 30 minutes to fall back asleep, that's typically starting to become beyond the range of what's developmentally appropriate or expected. And then lastly, so we went from If we went from initiating to middle awakening to early morning awakening with difficulty returning to sleep. Operationally, this is a little bit more difficult to define, and in our criteria, you could see it's a little bit less clear. At the very least, it requires 30 minutes before the scheduled time of awakening. Others will say that that's too short, that if it should be 60 minutes or 90 minutes, or before the total sleep time is 6.5 hours. Now, you just heard what some of the developmentally appropriate expectations are for sleep, such as 11 hours for certain kids. So you could see for an adolescent, 6.5 hours isn't bad. For a middle school age child, that's quite a bit of shortening of the total sleep cycle. So the definitions of early morning awakening are a little bit more subjective and not as well operationally defined. As we move on into our criteria to help define whether this child meets the diagnosis of an insomnia disorder, our DSM-5 usually includes one of the criteria being that not only is there severity of these symptoms there, but the other domain is there has to be present either significant distress or impairment in certain areas of functioning. Now, why is it both? Because a significant distress can be internal and not necessarily appear to be an outward impairment, or there's an impairment in functioning, such as difficulty in concentrating at school the subsequent days, difficulties in the relationship with the parents as a consequence of this. And along with the criteria involves the frequency and a duration criteria, so that these symptoms must be present at least, or occurring at least 3 nights per week, and be present for at least a period of 3 consecutive months. So you can see we have some time frameworks for each type of sleep pattern, and then there is a frequency criteria, and then there is a duration criteria, and then the need to create some kind of impairment in functioning. And then needless to say, the other typical criteria involve issues such as it's not better explained by some other disorder, whether some other sleep-wake disorder or some other physiological causes such as caffeine or iatrogenically medication-induced sleep issues, as we see sometimes with the stimulant medications in children with attention deficit hyperactivity disorders or any other medical disorders. Now, those things are important because that helps, again, provide a framework as to what is considered developmentally appropriate and then what starts transitioning into a clinical realm. And a clinical realm then suggests the need for some interventions, not necessarily medications, but needs some medications. Now, parasomnias are different than dysomnias because parasomnias involve disruptions in your regular sleep or an existing sleep pattern. And it typically gets manifested by either arousals or partial arousals or difficulties with transitioning from different phases from REM to non-REM sleep, etc. Insomnia per se, or excessive daytime sleepiness, is less common in parasomnias. As you can see, obviously, it's more common with the dysomnias. Parasomnias can come and go, and they typically get better with age, and they affect kids that are otherwise healthy, that they don't have any other major medical problems, whereas insomnias tend to be more frequently associated. They don't have to be, but they tend to be more frequently associated with other disorders, behavioral health disorders such as ADHD and or depression or autism spectrum disorder, etc. And therefore, parasomnias are frequently viewed as being these kind of transient developmental phenomena because, as I mentioned, they tend to the natural course of the parasomnia tends to run and improve over time. And so that's also important to know, because we just mentioned insomnias can be lifelong, whereas parasomnias, when you look at the course over time, generally tend to get better over time. And so that's an important factor to discuss with the parents, and that hopefully we give them some hope or provide some of that education on those nights when they're dealing with their child that's displaying these. And some of the typical parasomnias include the non-REM sleep arousal disorders, which is the sleep terror disorders, or what we used to call night terrors, where the child would wake up and be agitated and yelling and even physically or motorically increased, such as kicking, etc. A nightmare disorder or nightmares. The REM sleep disorder. So during REM sleep, there should be this kind of hypotonia, or kind of this almost paralysis, where there should be very little motor activity. But in a REM sleep disorder, the child during those periods of REM displays all this motoric activity that it would not be typical otherwise. And lastly is RLS, or restless leg syndrome, which is both the subjective and feeling restless or having to move one's legs, or characterized by the actual displaying an increase in motor behaviors that tend to get worse in the evening and obviously during sleep. And so you can see these type of disorders, we're not going to discuss the treatment of the medications we will discuss today will not address parasomnias, because there is already a paucity of literature addressing insomnias or sleep issues in kids, and there's even much less literature addressing the pharmacologic treatment of parasomnias in kids. And so the hope is that these can be managed, either better managed behaviorally, and or hopefully over time they will run their course and will just improve as children progress. A brief overview. Remember my disclaimer earlier that the expectation should not be a comprehensive overview of behavioral interventions, that we're going to in a second get to the real basic use of medications for the frontline practitioner. But just a brief overview. And if you email Sabrina Singh, as was mentioned earlier, she will provide you the slides, and there's an appendix with a few more slides looking at some typical techniques for parents to help them address some of these behaviors in a more concrete fashion. But the behavioral interventions, obviously, the younger the child, the more caregiver implemented they are. And there is a variety of different interventions that are implemented, and we'll get to the CBTI in a second, including the typical healthy sleep practice. We all know the need to keep the schedule and the routine as regular as possible, the avoidance or the limitations of the exposure to the screen time we call it, the clear limitation of caffeine or other caffeine products with caffeine, and obviously looking at what's appropriate for napping as well. Cognitive behavior therapy for insomnia, CBTI, is an intervention that has been developed over the past few years that extrapolates from cognitive behavior therapy theory. Cognitive behavior theory works on helping an individual change their patterns of thinking, and typically involves these distorted thoughts or changes or attributions. That means what we give meaning to, and then the subsequent behaviors associated with them. So this form of CBT, cognitive behavior therapy, is aimed at changing the sleep habits and the structure of the child's routine, and then addressing as well any misconceptions or misattributions related to sleep and insomnia, etc., that perpetuate the sleep issue. Needless to say, CBTI is much more effective with older children and adolescents, and typically children, adolescents, and parents that are motivated to do the work. Because it is work. It isn't just coming in and saying, here's what you do in this formula. There is work in between sessions. It involves components such as the sleep restriction, how to work with the parents on stimulus control, as we just mentioned earlier, reviewing all of the sleep hygiene that we know as well, and then really looking at the relapse prevention portion of it, is that once the sleep is better, how does that parent help that child or adolescent maintain their sleep, and how to intervene early, and how to maintain those healthy habits over time. And though the CBTI is typically implemented or facilitated for the parents by a psychologist or someone who has a very specific training in that procedure. So now, that was by way of introduction, so let's get to it. That's why I said about the movie. I say, gee, there's a crescendo. The movie was great in the second half. That's where the plot took off. And now we're going to talk about medication treatment of pediatric sleep disorders. And as we look at our decision making on this, as we mentioned earlier, we try to make the guidance is provided depending on the levels of scientific evidence. And as with most either treatment guidelines or even practice parameters, we look at the strength of the scientific evidence. And this is the levels of scientific evidence pyramid that was adapted from the SAMHSA website, I believe, or Department of HHS, of which the gold standard are randomized controlled trials. That is, that we know that those are the most elegant trials, and that the stronger the evidence, the further up on the pyramid, the more confidence there is in making the recommendations. So that as we move into each of these classes of medications, you're going to see that the recommendations for use are based on the strength of that evidence, as well as consensus of experts in the field. But that these recommendations do not in any way replace you or any prescriber's clinical judgment, but that they help guide the decision making, and that they permit appropriate decision making as you go along the way, but that it's not linear. You could say, gee, I'm going to start with this, or no, I'm not going to start with this. I'm going to start with this over here because I think it's more appropriate and it's justified by X, Y, and Z. Because ultimately, the prescriber is responsible for justification of the decision for the use of the medication. Needless to say, before you start any medication, there needs to be a comprehensive assessment. Again, we're not going to get into all the details of what that entails because we want to assume that all of these are already being done. But just for the sake of thoroughness, we're going to cover them, that you want to rule out any comorbid or any potential causal factors such as medical problems. As we mentioned, sleep issues are very frequent in psychiatric disorders such as ADHD, autism spectrum disorder, and depression. And then iatrogenically or medication-induced sleep issues. And then the classic example being the stimulant medications, especially the longer acting stimulant medications, where kids that get started on medications, these stimulants, and get a second or a booster dose later in the day, which then interferes with their ability to initiate their sleep. And then that assessment needs to look at what the caregiver's role is. What is the parent doing or not doing to help facilitate the sleep? And I always joke with parents, please, mom and dad, remember, you got to take your child home so we can talk about all this. And I know how difficult it is at night, but ultimately you're the one there on the front line every night after a long day at work that has to be able to implement these things. But that these are the typical scheduling, sleep hygiene, behavioral interventions that need to be done to help promote healthy sleep. And it is work, so that you review all that history with them before you get to even consider medications. So let's talk about the most frequently used medications. And today we're going to talk about these. We're going to start with melatonin, diphenhydramine, commonly sold under the commercial name Benadryl, Clonidine, trazodone, Murtazapine, the benzodiazepines as a group, and then amitriptyline. This by no means is a comprehensive list, but this tends to be the most common medications that are used, and that typically you'll see, oh yes, by the way, I've used this or that, but that these are the most commonly prescribed medications. So we're going to start with melatonin because melatonin has the largest literature base or supporting evidence. And so you will see that many of you know melatonin. Melatonin is a hormone that's naturally produced in the pineal gland, and it's derived from the amino acid tryptophan before it gets converted into melatonin. Then the secretion of the melatonin is controlled by the hypothalamus, which is obviously the site of our biological clock, that regulates the sleep and the wakeness and the tiredness. It starts appearing in the concentrations in our blood start increasing in the early evening. This is somebody with a typical day evening schedule, and that the concentrations peak about 2 or 3 in the morning, and then decrease and are nearly undetectable by the time the morning comes, right around breakfast. Again, we're not talking about people with different shifts or schedules. This is your classic stereotypical sleep-wake schedule. And in reviewing the literature, there is a general paucity of literature, of well-designed literature looking at sleep meds in children. But in melatonin, you'll see that there is a fair amount of work looking at its effectiveness. These last 2 studies listed on there are the same study. It's just that the 2013 study looked at the subjective aspects of the melatonin use. That is, how rested did I feel the next day, what kind of quality did I have the next day, etc. And that the 2014 publication of that same cohort and that same group looked at the more objective sleep issues, such as the duration of sleep, the latency, the time falling asleep, the number of awakenings, etc. So that in reality, those are all one study, just 2 components, 2 publications out of one study. But you can see that there's at least 3 randomized controlled trials supporting the use and emphasizing the short-term use of melatonin in children and adolescents, with the most recent one being in 2010. Other studies looking at that are more open label or retrospective studies, but also in the 2000s, etc. And interestingly enough, that same study referenced on the previous slide and their continuation after the 2 weeks of their study going on for 3 months, they found that both the subjective and the objective parameters of sleep improved in the kids in the continuation phase of that study, even though it was open label. Melatonin has been, and that's in the neurotypical and the general pediatric population, melatonin has been studied quite a bit in children and adolescents with neurodevelopmental disorders, such as autism spectrum disorder, intellectual disability, formerly known as mental retardation, etc. And that there have been more randomized controlled trials examining its use, and that in all 13 studies in these populations, it's been shown to be effective. And that also applies for some of the literature in the ADHD studies as well, so that when we move from the general pediatric population into a specialty or more clinical populations, there is a fair amount of literature as well supporting the use of melatonin. Melatonin, as you can imagine, the most common side effects associated with the use include daytime sleepiness, that proverbial carryover effects. Headaches can be a limiting factor, and in some of the studies, and in real life, lead to dropouts or discontinuation of use, and dizziness. And then less common side effects include the abdominal discomfort, emotional changes such as irritability or anxiety, and even some transient feelings of depression, as well as some confusion the next day. Melatonin, being an over-the-counter product, is not innocuous either. You want to consider its interactions with others, especially metabolically. It's metabolized by cytochrome A1, 2, and they interact with certain medications. And this is why there is a small amount of controversy about its safety, because as you could see with all these medications, the focus is on the efficacy rather than the safety. So that in that same vein, there have been no long-term studies addressing how safe melatonin use is in kids, that is. And so the National Center for Complementary and Integrative Care, which is part of NIH, says that melatonin seems to be safe, but that there aren't any studies. So they upgraded it from possibly unsafe to it seems to be safe, but that in reality, we don't know. And that despite of this, it's generally regarded by most practitioners as being relatively safe, and that there's a need for further trials and examination of the safety issues. Now, melatonin for a typical hypnotic dose, that is to help the kids fall asleep, is usually 2.5 to 3 milligrams in kids, 5 up to 10 milligrams in adolescents. Generally, above 10 milligrams, we don't know, or you're not going to get much of a clinical effect. And there is no data in kids under 2 years old. Typically, for the hypnotic effect, you want to administer it 30 to 60 minutes before bedtime. You don't give it right when you do not have the child take it right when they're going into bed. And then obviously, as with all over-the-counter products, that there isn't the same regulatory control of quality as you would with a pharmaceutical. So therefore, differences in responses could be explained by the differences in the proprietary brands. Of note is the melatonin does come in an extended release or a longer acting preparation, which lasts anywhere from 6 to 8 hours, but there was no literature examining their use in kids. And so some people extrapolate from the short-term use to sometimes using the melatonin extended release for kids that have problems staying asleep throughout the night. Now, melatonin, so another way to use it is called chronobiologically, that is to help it simulate the body's normal rhythm or excretion of melatonin. And that's different than the hypnotic effect that helps kind of put the child to sleep or sedate them, if you will. And that's where all the studies looked at. There haven't been studies systematically looking at its chronobiologic use. So in order for melatonin to help augment the normal body's secretion of melatonin, it's given much earlier. And the effect is going to be different because it's not going to necessarily, quote unquote, knock the child out. So for these chronobiological uses of melatonin, the doses are lower. Then 6 milligrams, some authors report as even being aggressive. It should be much lower. And it's usually administered up to 6 hours before the typical bedtime. So if that child's going to bed at 9 o'clock, it gets administered right after school. If it's a teenager who's going to bed at about midnight or 11 or supposed to be, it gets administered at 5 or 6 p.m. And it takes a lot of education in working with the child or adolescent and the parents, because the expectation is not to sedate them and they're not to knock them out as you would with the other dosages. And as I mentioned previously, the literature and the studies haven't examined this as of yet in a very systematic way, but that in general, this is what we know from the adult population. This is what we know from the pharmacokinetics and the body's biology. Now we're going to transition to clonidine. So you can see there's a fair amount of literature with melatonin, but with clonidine, a medication that is used relatively frequently, there is much less literature or research. Now, being an alpha-2 agonist, clonidine was originally developed for high blood pressure, for hypertension, but that it has been used extensively in clinical populations to help with sleep. And there has been some work in the population of kids with autism spectrum disorder, ASD population, which helps not only decrease the sleep latency, that is falling asleep earlier, but reduce the number of awakenings for those children that have middle awakenings. One of the issues with clonidine is it comes in an extended release form, so we don't know. So one generally starts with the immediate release clonidine for sleep, and then sometimes people decide, well, if clonidine is effective, why not use guanfacine? Guanfacine is a less centrally acting alpha-2 agonist, so it tends to be a little bit less sedative, but people will sometimes say, hey, the child will have less of the carryover effect the next day, and we'll get that same desired effect. There is no literature or no trials to guide that treatment, so it becomes an empirical or decision or judgment. Issues with clonidine is that the child may develop tolerance over time. That is, they're taking 0.1, they're taking their dose, and then it seems not to work as effectively. Since it is an antihypertensive, the blood pressure and pulse needs to be monitored, and one should avoid abrupt discontinuation. That is, if the dose gets escalated, you want to be careful about just stopping it, because there could be this rebound hypertension that results. The most common side effects, as you can imagine, include drowsiness, dizziness, especially if the child and adolescent is predisposed to postural hypertension, getting up at night to go to the bathroom and things like that, dry mouth, and constipation. And then some less common side effects, as you can see, mentioned at the bottom. The typical dosing is here. You can see you start very low and you go increasing weekly, and it's increased weekly until either there's a desired improvement in sleep, or there are rate limiting or there are dose limiting side effects. That is, we've increased the dose, the sleep's not better, but there's these side effects, so therefore it's not working and we're going to move on. It's not producing the desired effects and we're going to move on to the next medication. Diphenhydramine. We would be remiss if we didn't talk about diphenhydramine, one of the most utilized medications as a sleep aid, categorized by the FDA. There have been 5 controlled studies of the use of diphenhydramine in kids with sleep disturbances, and adults, right? The results have been mixed. There's been only 1 randomized controlled trials involving children, and there have been no studies since 1990. And so this is one of the issues that gets brought in, is that the literature is all old. So even though there is 1 randomized controlled trial with kids that showed improvement in these sleep parameters, there have not been any major studies or any well-designed studies in the last 26 years. There's a whole group of studies involving adults, and the last one on this list that involves some older teenagers, that have very mixed results and very different populations. And so therefore the results in the studies are basically very mixed and difficult to interpret. The most common side effects of diphenhydramine include, as you can imagine, drowsiness, dizziness, not too dissimilar from the clonidine, stomach upset, blurry vision, etc. And then the other thing is to watch for in kids is that rarely, but we do see this kind of paradoxical excitement or agitation. Instead of the kids being calmer and quieter, they get activated and don't sleep. The starting dose is small, and it gets titrated up as needed based on the clinical response again and body weight. And there are no clear parameters for discontinuation. That is, when do we know when to discontinue it? So Clonidine is another option, but you could see, although it's used quite frequently, the literature is more scant on it. Murtazapine, sold commercially as Remeron, is a frequently used medication. It's an antidepressant that has very sedative side effects. There's limited evidence for its use in kids, only one small open label trial that was relatively well, about a third, if you consider that well, kids that responded. The predominant side effects with Murtazapine or Remeron are obviously sedation, but increased appetite and weight gain. So especially teenagers and especially girls tend to balk when you have these discussions about the potential side effects. It's dosed in 15, 30, and 40 milligram tablets. That's the dosing, and that it comes in. Usually you try to start with either half or a smaller amount of that tablet, depending on the child's or the adolescent's age and size, and then increase it as needed. It's also available in this kind of dissolving tablets, which helps for kids that have difficulty swallowing. And in benzodiazepines, even though they get mentioned, there are no controlled studies in the use of benzodiazepines. They're generally reserved for kids with other comorbid issues or very time limited or time, as with all these issues, such as some traumatic or catastrophic event. But again, similar to diphenhydramine, it can cause this paradoxical excitement or worsening of symptoms. Traceroune, sold commercially as Deserel, is used quite frequently in the adult world and not infrequently with adolescents as well. It is an antidepressant that has very sedative properties. Side effects, there are no controlled studies for its use in sleep disturbances with children and adolescents. Aside from the typical side effects of sedation, dryness, constipation, maybe orthostatic hypotension, for boys there is, although not infrequent, the possibility of priapism as well. Begin low, begin with a 50 milligrams or a 25 milligram tablet if that's the indication, if that's the medicine to use, and it gets increased by about 25 milligrams per week until you either reach the desired behavior or there are limiting side effects where you say, gee, it's not helping, but these side effects are too severe and we need to discontinue. And amitriptyline is an older medication that used to be sold commercially as Elavil. It's sometimes used for pain as well. It's a tricyclic antidepressant. Again, there are no controlled studies in children and adolescents because it is a tricyclic antidepressant. It's associated with lowering the seizure threshold, and especially in adults. But if there happens to be a child with any pre-existing cardiovascular disease, there are risks because of the effect on the QT, on the electrophysiology, and so there should be a baseline EKG done. One begins very low, either at 12.5 or 25 milligrams at bedtime, and again, it's increased weekly until the desired effect is achieved or the rate-limiting side effects cause that it needs to be suspended. And then there's a whole slew of herbal supplements which are sometimes used. These can or cannot have benefits. There is obviously a paucity of good studies examining these. And certainly if there's very little literature on the medications, they'll be these products will be less well studied in this age, in this population. Of note, always the disclaimer, and of note is that antipsychotic medications such as quetiapine or risperidone or any of the others in this class should not be used or not recommended for the treatment of insomnia solely. This happens frequently in the adult population, sometimes with adolescents, but because of the potential for all these more serious metabolic effects, such as the weight gain and then all the subsequent issues that happen with weight gain over time, and especially since they're also used for maintenance, they're just continued, that it becomes a problem. So summarizing, medication should not be prescribed when there's a parent-child issue. There are no medications currently approved by the FDA for the treatment of pediatric insomnia. These medications have some support for their effectiveness or efficacy, but there is insufficient evidence on the safety profile and on specific dosing of these medications. So that in general, we know they work some, but there's a need for much more literature. That medication should be considered in the short term if the insomnia results in significant impairment and the caregiver is also impaired from their performing their duties because of the child's issue, or the behavioral interventions have been attempted and are ineffective, or the caregiver, you have to make an assessment, will not be able to implement that. And in certain regions of the state, it will be that they're not available either. The resources are not there to help with those interventions. They may be appropriate for these short-term interventions, especially crisis situations, and especially for certain psychiatric disorders for which there is a higher likelihood of these sleep disorders developing. And knowing that the sleep issues could also have the reciprocal effect and exacerbate certain psychiatric and or medical conditions. Needless to say, we discuss it. You begin with your comprehensive assessment of what's going on, and the initial treatment should typically be behavioral. And then if the child still meets that threshold, say medications are indicated, I think that it's of sufficient, as in general rule, the two big parameters you heard are sufficiently severe and it's creating sufficient impairment, I will look at the option of using one of these products. And I was including melatonin as a medication, but it's not a medication per se. And that there should be some well-defined endpoint for the use of these products, and that needs to be discussed with the parents up front. That these, for maintenance purposes, it becomes a little bit less clear what the benefits and the risks are over time, so a lot of caution should be there. The exception being when it's part of a treatment plan of some major psychiatric disorder, such as treatment of ADHD, where there are sleep issues that are either inherent to the child's, it's a primary insomnia, or they're secondary to the use of the medications. In general, melatonin is considered your first line product to use. You heard those parameters, you heard the reasons why. You also heard what some of the limitations are of what we don't know with melatonin. And then from there, it's either clonidine or diphenhydramine. It's the literature's mix, so it becomes more of a clinical judgment whether what's more acceptable to use a diphenhydramine and being over the counter and more easily to dose, or clonidine, depending on the severity and the use. And then after that, after those medications, the literature is much more limited, and these other products can be used with caution and hopeful justification, but one needs to be aware that the scientific basis for the justification and scientific guidance, the literature guidance on the use of these products in kids and children and adolescents is very, very limited. And I'll repeat it again, that antipsychotic medications alone for the treatment of insomnia or sleep disorders usually are not recommended. The incidence, the issues, the metabolic issues that far outweigh any potential short-term benefits from using these medications. A brief table giving some of the dosing guidelines that we talked about, of how to start and how to titrate up. Needless to say, these are rough guidelines depending on the age of the child. The melatonin could be started even at a smaller dose, but that these are just rough parameters on how to titrate up and how to move on. This table talks about the titration being a tiny bit more aggressive if you want, or being daily or weekly, but that in general, the rough rule is per week. One starts something and utilize it for a week. The caveat is there'll be parents who are saying, I can't wait. They haven't responded after a day or 2 days or 3 days, and there's a little bit of a crisis in the household. So from a real world perspective, the parents, we sometimes more aggressively titrate the dosage. So on that note, I hope that we all benefited from this brief overview of the use of medications for sleep issues in children and adolescents. Our children, as we all know, are our future, and we're all involved in helping them be healthy and lead productive lives. And hopefully, as you go to your practices, you're able to use some of this information in guiding your decision making. Thank you for participating. And the question reads, since virtually none of the medications you have discussed are studied or approved for insomnia management in children, why are we not considering non-benzodiazepine agents like Zolpidem, that is actually a true medication, as well as Rosuram, which is a melatonin analog? Also considering the fact that Melatonin can be guaranteed, unlike melatonin. Well, those are very, very good questions as well, because that's exactly right. There is no literature to guide some of those decisions. And so when we have our meetings, we have our discussions and review the literature, when there is at least a literature based on something like melatonin, we recommend it. But we know in the real world, ensuring the quality, because we'll even go and say, gee, you should try to get this pharmaceutical grade melatonin, but it's basically very difficult to ensure and get. So you're right, and one of the reasons why we stay away from that, because there are very, very little support for any of these meds in kids. So sometimes we will use those meds in older adolescents, extrapolating from the adult literature, as you mentioned, as a way of saying, okay, it's a lower level of evidence and we will consider using it. But we continue with the recommendation of melatonin because at least that literature base is there. Now, finding the best product, that's another challenge. And we see that same thing when people bring up the question about omega-3 fatty acids and which ones to pick. Thank you, everybody.